Hello everyone, welcome back. This is week 2 of our mental health course. Congratulations on making it through week 1. I do think that week 1 is the most difficult concepts to grasp. All the basic mental health nursing we covered, what's going on in the brain and how the meds work with the neurotransmitters, I think is difficult content. So now that you've made it to week 2, that's wonderful news. You've gotten through the worst of it. So from now through the remainder of the course, we're going to be working through specific disorders. And this week we will be talking about thought disorder, which we can also title as schizophrenia. So schizophrenia, the hallmarks of this condition are delusions and hallucinations. It is characterized by withdrawal from reality, such as delusional thinking, sensory distortion, illogical thought patterns, and ineffective communication. Schizophrenia is a permanent handicap in thinking and learning. There is no cure for schizophrenia. Basically, what we're attempting to do is manage symptoms. So to talk a little bit about the epidemiology of schizophrenia, it is a lifetime disorder. It affects approximately 1% of the population worldwide. So it is not a very prevalent condition, but it does affect 1%, so it is important that we understand this disorder. It is more prevalent in men. There does not seem to be any difference related to race, social status, or culture. It usually presents during the late teens to the early 20s. Excuse me. Prior to onset, individuals often do very well and are able to hold jobs and get good grades in school. Early onset, as I said, is between 18 to 25 years of age. It's associated with poor functioning, more structural brain abnormalities, and increased levels of apathy. The late onset can be categorized as between age 25 to 35. At this stage, it is more likely to occur in women than in men. And it has less to do with the structural brain anomalies, and it has better outcomes when it's a late onset. So 40% of these individuals who are suffering from symptoms are not receiving treatment. If it is left untreated, it is obviously a persistent disorder and will continue to, what's the word I'm looking for, affect their ability to function, and their ability to function will continue to decrease. Patients will have a partial stabilization of their disorder when they're not on medications, and then they will have periods of relapse. Childhood schizophrenia is very rare. So what are some comorbidities that we find with schizophrenic patients? One of the most common is substance abuse disorder, especially nicotine dependence. It's approximated that about 50% of schizophrenic patients will be using some kind of a substance as a way to cope with their symptoms. Obviously, substance abuse will increase their health risks for future diseases. Anxiety and depression are very common with comorbidities of schizophrenia. It's estimated that about 10% of persons with schizophrenia also will have anxiety and depression. This population is at an 8.5 times increased incidence of committing suicide than the general population. Physical illnesses or comorbidities, they are almost 3 times at risk for premature death, and that probably goes along with the substance abuse and the suicidal tendencies. Patients with schizophrenia tend to die 28 years prematurely than the normal population. Again, we're thinking suicide, but some of their comorbidities also contribute to this early death, such as hypertension, obesity, cardiac disease. Oh, excuse me. I'm going to have to pause for a minute. Okay, so I am back. You guys are probably wondering, what is wrong with this woman? She coughs all the time. My 8-year-old son, obviously, he's brought home some kind of a respiratory thing from school, and we've been struggling with this for about a week. So I apologize for the previous recordings where I was coughing. The other one, I didn't know how to stop the recording, and now I do. So here we go. I believe we were on physical health illnesses. The risk of premature death is 3 times greater than the general public for people who have schizophrenia. And this is can be accounted for because of increased self-harm and other disorders such as hypertension, obesity, cardiac disease, diabetes, chronic pulmonary obstruction disease from smoking, and then the trauma, like we said. And if you remember back to our discussion regarding stress and crisis, the longer that a person is under stress, the more likely they are going to have long-term side effects throughout the body from that increased stress level. Persons with psychotic disorders may be at a greater risk due to apathy or this poor health habits, medications that they're on, poverty, limited access to health care, and failure to recognize the signs of their illness. And if you remember, one of the side effects of medication was the polydipsia. So we actually can have fatal water intoxication symptoms caused by hyponatremia. Polydipsia occurs in about 20% of the persons with schizophrenia, and it's that insatiable thirst that results in the hyponatremia. And again, it's caused by the medications and sometimes the compulsive behaviors. So what is the etiology behind schizophrenia? What causes these problems to occur? The biological aspect or the genetic component plays a huge role in schizophrenia. 60 to 80% of people with schizophrenia can be traced back to a family line of schizophrenia. So it is a inherited gene abnormality. If both parents have schizophrenia, the child is going to be 50% have a 50% increased chance of having schizophrenia themselves. There also is the neurobiological component, that is the disorder of the neurotransmitters, specifically dopamine and serotonin. In schizophrenia, both dopamine and serotonin tend to be at high levels. Psychological and environmental factors, basically these are the stressors that occur during brain development. So like prenatal stressors could be viral infections, poor nutrition, maybe during the birth process there was some hypoxemia, maybe the mother was exposed to some toxins or took some medication. It's also been found that if the father happens to be 35 or older during conception, that also contributes to the likelihood of schizophrenia. So other stressors could be trauma to the mother during pregnancy. Some environmental stressors could be high levels of stress in the mother during pregnancy that increased her cortisol levels and ended up impeding brain development in the infant. So if you look at these images that I put on the slide, the first one, schizophrenia in twins. So one twin does not have schizophrenia and the other one does. And if you examine the pictures, what you will see is that there is an enlargement of the ventricles. The third ventricle is dilated, okay? And that is that butterfly-shaped image there. You can see the one on the right is larger than the unaffected child. They've also found that there's reduced cerebellum volume, especially in the frontal lobe. There's an increased size of the fissures, the little wrinkly things on the surface of the brain, and the thickness is also reduced. So there's increased size of the fissures and decreased thickness, which all results in reduction in connectivity in the brain regions. So brain structure abnormalities in the frontal lobe, as I had indicated or mentioned a minute ago. So if on the slide are all the normal things that the frontal lobe is supposed to do for us. So I consider the frontal lobe like the executive, right? It's our problem solving, our cognitive flexibility, our social awareness, our insight, impulsivity, and judgment, abstract thinking. So if you can think of the frontal lobe as the executive. Okay, I have to pause again. Excuse me. Okay, if I make it through this lecture, I will be completely amazed. So again, what we have listed on the slide are the normal functions of the frontal lobe, and we consider this the executive, okay? And most schizophrenics, have some degree of frontal lobe abnormality, as previously mentioned, especially like the cerebral volume. So they are hindered in all of these aspects. So they typically will have lack of insight to common problems and inability to think abstractly. Many have problems understanding why they need to continue to take meds if they're feeling better. They don't understand that the medications are keeping them well. So here's an example of something that a schizophrenic would do. So if the schizophrenic person was supposed to be to work at 9 a.m., but they showed up at 9:15, the boss says to them, "It is 9:15. The schizophrenic person would state, "Yes, it's 9:15. They aren't able to understand that the boss is actually upset with them because they're late. That's just a simple example. Another area of the brain that is affected by schizophrenia is the temporal lobe. The temporal lobe helps us with perceptions, reality orientation, our memory, okay? So I think of the temporal lobe as our reality checker. Most schizophrenics have problems with this area of the brain. So you're going to see abnormalities in their perception. What we perceive from the outside world, from our five senses, normal people would process. So a normal process would be, if I hear a voice, the temporal lobe would take that message and send it to the frontal lobe to process. So it's a problem with perceiving the message, and the frontal lobe cannot execute appropriately based on that misinterpreted message. And as we just talked about a minute ago, so the temporal lobe, if there's a problem here, the message is getting screwed up, and then it sends it to the frontal lobe, which is our executive lobe of the brain, and there's a dysfunction in the frontal lobe also, remember? So between the two of them, things get really messed up. So an abnormal process of perception for schizophrenic patients is going to be hallucinations. So in the schizophrenic patient, when they hear something imaginary, the temporal lobe misfires and sends the impulse to the frontal lobe. And it's there that the perception is perceived as real to the person. So the image on the screen of the cats, okay? What the story is behind that is there was a gentleman named William Wayne. He was a textile trader in the 1800s, and he had schizophrenia. And he loved to draw pictures of his cat. What the picture shows is as his disease worsened, his perception of his cat changed dramatically. So if you look at the series there of cat pictures, by the end, you wouldn't even be able to recognize that that was a cat. Finally, with the temporal lobe, there are those abnormalities in reality orientation. And this usually comes out in delusions, okay? Delusions are different than hallucinations. Delusions are fixed thoughts. So fixed things that they believe are true, even though they are not true, and they cannot be swayed in any way. If you present them all kinds of facts and reality, they will not be swayed from what they believe is true. They will hold on to that belief no matter what. So, an example of a delusion is if they say the CIA is bugging their room. Paranoidal thoughts, paranoid delusions are very common with schizophrenic patients, and it only leads them to more increased stress, anxiety, and fear. The final brain abnormality that is going on with schizophrenia is within the limbic system. Again, on the slide shows what the normal functions of the limbic system are. I call this system the switchboard operator, right? It's moving the message from one place to another. So in schizophrenic individuals, they have found on imaging that there is actually a tangle of neurons in this area. So the message does not go where it's supposed to go. Meaning, if they hear something, it should go to the, if it was supposed to go to the right part of the brain to be understood, what happens is it goes to the other side of the brain, or it goes to a different part of the brain it's not supposed to. Okay? So often this is going to result in some symptoms you're going to see with your schizophrenic patient, and that would be loose associations, okay? So let me give you an example. So a man is talking about his garden, and he's working in his garden, and he's pounding the stakes in to, label his rows and whatnot. And the individual with schizophrenia is there with him, and he's listening to the guy talk about his garden, okay? And the schizophrenic patient might respond, "Oh, I had steak for dinner." "No, I had chicken for dinner. It was Kentucky Fried Chicken, the Colonel." "I was in the Army once." They have this just loose, like, statements that don't connect at all to what the conversation is going on. And the person who's listening, so the gardener or the man in his garden who's listening, have difficulty following the progression of thoughts that the person is saying. It's just completely disassociated. Another symptom you might see from the limbic disorder is what we call word salad. Okay, what that means is the schizophrenic person just uses random words, and there's no association to anything. Okay. And then finally, an inability to access their memory. So schizophrenic patients will often have problems with their own identity. Oh, I was wrong. There is one more area that is affected by schizophrenia. I said the last one was the last one. This is the last one. So basal ganglia. Again, here are the normal functions in the basal ganglia. We can think of this area as the filter. So in schizophrenic patients, they often cannot concentrate. They can't filter out distractions. They can't close that gate between the outside world and being able to focus on what they're doing. So an example of that would be we're all in a classroom together, right? And our classroom, even though our classroom doesn't, but our classroom has windows. Now, if we had one schizophrenic person in our class with us, that person, every time a car went by the window, would not be able to concentrate on the course, the lecture. Instead, every time the car went by, they would be distracted and they would be watching the cars, while other students would be able to block that out or filter it and wouldn't even notice that the cars were going by. So that's an example of inability to filter. I'm trying to decide if I'm going to break this up for you. No, we're going to keep going. So the earlier we recognize treatment for schizophrenia, the better it is for the patient. So how do we go about recognizing? So the first expression of symptoms of schizophrenia are going to be, again, between the ages of, say, 15 to 30. This occurs typically because the brain is growing so fast that those neurons can be damaged, okay? So the prodromal phase of the disorder is going to be insensitivity to others. You might have poor relationships. You might notice some behavioral problems. They may socially isolate themselves or have high anxiety. They may be emotional labile, and obviously they have difficulty concentrating. Now the later symptoms that you're going to see are the more extreme problems with the flat affect, the magical thinking, really bizarre, odd behavior, unusual perceptions. So often, first thing we're gonna see then again is, say, poor performance in their job or school. Maybe some alcohol or drug abuse because they're trying to self-medicate. Maybe problems with peers or their family members because they're unable to make those relationships. Okay. Now, there are four main symptom groups of schizophrenia. Positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. So you're going to want to know those four. What positive symptoms are is the presence of something that is normally not present. So that would be your hallucinations, your delusions, your bizarre behavior, your disorganized thoughts and speech. Okay? Negative symptoms are the absence of something that should be there. So alteration in emotional responses. There should be a normal emotional response and you don't get that from them. So it's an absence of something you would expect. Okay? Cognitive symptoms are obviously, as it says, abnormalities in how a person thinks. So you're going to have inattentiveness, you're going to have poor problem solving, you're going to have illogical thinking, impairments in their memory, poor decision making, impaired judgment, those kinds of things. And then affective symptoms are, again, changes in emotions and the expression of emotions. So we're going to go through these a little bit. Delusions, okay? Delusions affect about 75% of people with schizophrenia. And again, if you remember from a little bit ago, delusions are false, fixed beliefs that cannot be corrected by reasoning. This is a very important aspect of schizophrenia. So you want to star this and make sure that you understand what a delusion is, okay? It's important for us to know that when the patient is experiencing delusions, that we do not confront their delusion. We do not confront them with reality. After we've built up some trust with them, what we're going to want to try to do is to get them talking and to help them examine the evidence so that they can determine that their delusion is false. Okay? So there are different kinds of delusions. These are in your textbook, but what I want to do in the lecture here is just give you an example of each so that it helps you understand the different types of delusions. So control delusion is believing that another person or some external person is controlling thoughts, feelings, or their behaviors. So an example would be Brian covered his apartment wall with aluminum foil to block government efforts to control his thoughts. Okay? Ideas of reference. What this is giving personal significance to unrelated or trivial events. Okay? So an example of this would be Barbara believes that the birds sing when she walks down the street just for her. Okay? Persecution. Persecution is the belief that one is being singled out for harm by somebody else. So let's say Peter believes that the Secret Service is planning to kill him by poisoning his food. Therefore, he won't eat any. He will only eat prepackaged food. Okay. Grander delusions are believing that one is powerful or has some magical powers, okay? So an example would be Sam believes that he's a famous playwright and a pro tennis player. Okay, they have these false beliefs about themselves. Somatic delusions are believing that the body is changing in an unusual way. So like David said that his heart has stopped and is rotting away in his chest, would be an example. Jealousy, believing that one's mate is unfaithful, that would be another delusion. So another area, another positive symptom other than delusions is impairment in concrete thinking. So they're unable to think abstractly. So here's an example of that. If I were to say the glass is half full, the schizophrenic patient would be thinking you were talking about an actual glass of liquid, okay? Or if I said the cartoon of Dennis the Menace, he's taking his wagon over to Mr. Wilson's because Mr. Wilson stated next time I came over he would fix my wagon. So the schizophrenic patient thinks that fix my wagon is actually going to fix my wagon, not that he's a naughty boy. Okay? And then another positive symptom would be speech, abnormalities in speech. So they're going to use clang associations, that's words based on sounds. So clang associations might be on the track, have a Big Mac, or click, clack, cluck, close. They'll say things like that that have a rhythm, okay? Word salad we kind of already talked about, where they just randomly have these words that don't mean anything at all. Okay, this is hard to say. Neologisms, okay. What that is just made up words. It might be like they're talking their own language that they made up. And then echolalia is actually where they just repeat people's words. So if the nurse says, Mary, come get your medication, the schizophrenic patient might repeat, Mary, come get your medication. Okay? So here's a whole bunch of other symptoms. I just want to point out a couple of common ones. So the religiosity is a very, very common thing that the schizophrenic patients experience. Paranoia, the thought blocking, and the thought deletion are common ones that you might want to review. But this whole list and the explanation of each is in your textbook also. So positive symptoms, alterations in perception, okay? So we may have depersonalization. That's a feeling that one is somehow different or unreal, or they've lost their identity. So an schizophrenic patient might feel like parts of their body don't belong to them, or somehow they've drastically changed. So an example of this would be a patient might see their fingers as being smaller or more distant or not their own fingers, somebody else's fingers. Okay, that would be depersonalization. Derealization is a false perception that the environment has changed. Okay, so depersonalized was how they have changed. Derealization is how the environment has changed. So everything seems bigger or smaller or unfamiliar or strange, okay? Now, hallucinations, again, this is this perceiving a sensory experience for which there is no external cause, okay? So a hallucination differs from an illusion. An illusion is a misinterpretation or misperception about a real experience. A hallucination, there is no external stimuli that's causing the misperception. It's coming from inside the brain. So an example of an illusion, okay, an illusion might be a man sees a coat on a coat rack and believes it's a bear. Okay, so there is that external stimuli, which is the coat hanging on the coat hanger, and then the misperception of what that actually is. So that would be an illusion. Now, a hallucination, again, is an experience that comes from within the brain because of that problem with the messaging from the temporal lobe to the frontal lobe, remember? And this can affect any, or can come from any of the five senses. So there can be auditory hallucinations where the person actually hears voices. This is the most common hallucination. It is the voices, and it can be very frightening to the patient. And they may attempt to drown out the voice by loud music or talking very loudly, okay? There are also command hallucinations. This kind of falls under the auditory hallucinations. But what a command hallucination is that the voice is actually directing the schizophrenic patient to do something. This is a really important aspect to remember because this is where you're going to get where they may be harmful to themselves or harmful to others, because this auditory hallucination can be directing them to attack somebody or hurt themselves. So we always, always, always have to make sure that we are assessing for safety of the patient and others. So another hallucination can be visual. They can see things. They can feel things. They might have the sensation that there's bugs crawling all over them, obviously when there's not. They can have olfactory, where they smell things that aren't there, or taste things that aren't there. So, you know, the nurse tries to help the patient manage these symptoms So if there's a voice, providing them headphones to listen to music or something to drown out the voice. If it's a visual, maybe having them watch a movie to distract them from the visual hallucination they're having. If it's tactile, maybe we would offer a massage or rub the body part that they feel is crawling with bugs to try and offset that sensation. And then taste, if they're having abnormal taste, we could offer them some sugar-free candy or sugar-free gum, and that's also going to help them with some of the side effects of the medication, the antipsychotic medication they're going to be on. So this is just a slide where I tried to summarize the difference between these three concepts just to help you. Other positive symptoms related to alteration in behavior, I'll just point out the most common. Bizarre behavior. You are going to notice bizarre behavior. Inappropriate clothing, appearance, how they socialize, their sexual behaviors, inappropriate aggression or agitation, that repetitive motor patterns like twirling the hair, okay, that bizarre behavior. Catatonia is something we also see with the schizophrenic patients. Also, what goes along with the catatonia might be that waxy flexibility where the nurse might actually like raise the patient's arm and the patient continues to hold the arm up in the air. It's like they're stuck there. So kind of like statue-like manner, okay? The other ones you can review, but those were the three most common ones that I wanted to point out for you. Now finally, oops, excuse me, I just knocked off my glasses. The last thing I wanted to talk about here was negative symptoms. Remember, the negative symptoms tend to develop more slowly than the positive ones, and they affect or interfere with the person's ability to adjust or cope, okay? So negative symptoms impede the person's ability to initiate and maintain conversations and relationships. It impedes their ability to obtain or maintain employment. It impedes their ability to make decisions or follow through on plans. It impedes their ability to take care of themselves. So you'll often see hygiene and grooming problems. So negative symptoms contribute to poor social functioning, social withdrawal, and ability to function within their environment, if I can put it that simply. So things you're going to see are problems with affect. They might have flat. They might be blunted. It may be inappropriate or it may be bizarre. Other negative symptoms might be affect blunting or anergia, which is the lack of energy, or anhedonia, which is the inability to experience pleasure. The inability to have any motivation, poverty of their speech. Their speech conveys little information, is vague or superficial. Poverty of thoughts, okay, so you might have thought blocking, where all of a sudden the person is talking and then they stop, and that's it. That's the end of it. It's like they hit a wall, okay? And so how the nurse might respond to something like that, the nurse could say, "What just happened then?" And the patient might say, "I forgot what I was saying," or "something took my thoughts away," or something like that. So again, we need to make sure we are assessing for depression, substance abuse, suicidal risk, harm, and harm to others. Safety is always going to be your number one concern. So we will stop here, and we'll pick up the next lecture with schizophrenia and the nursing process. Thank you. And I made it. I didn't cough very much. All right. Bye.